a lot of the therapeutics that we're testing in rare diseases, because there's so few patients, it's treated almost like emergency medicine. It's a little bit different. If you were to develop a therapeutic for Alzheimer's or Parkinson's, I'm going to say the path to FDA approval is a little bit of a slog, right? You have to go through multiple clinical trial designs. There's placebo controls, there's dose escalation. There's a lot of things that go on in a clinical trial that don't necessarily happen for rare diseases. And that's for two reasons, or at least two reasons. One, we don't have enough of a patient population to do that, right? There's no double-blinded, placebo controls or dose escalation when you only have a handful of patients. You're really looking at the treatment of these of these kids as individuals almost, and a lot of this is individualized and of one studies. I think the other component of it is that there's just definitely a sense of urgency. This isn't, for some of these patients, they're not going to live long enough for a therapeutic to go through, and so there are accelerated pathways that we have through the FDA that allow us to say, can we take this ASO and test this therapeutic in this particular child? Can we take this, gene editing and test this in this particular disease? Because there's enough of an urgency. If you do nothing, those children are going to die, right? And so they become the way that a lot of these therapeutics are going to be validated, because certainly the parents want the opportunity to try. They don't want to just go home and love their kids until they pass away. They're going to do everything they possibly can to move these genetic based medicines forward. And with that and the number of rare diseases, we're going to learn a lot very quickly about ASOs, just like we did with gene therapy. We learned about different viruses, we learned about different tropisms, we learned about what's toxic, we learned about high doses, we learned about routes of delivery and administration, and we definitely learned what the immune system will do in the face of a high dose. And so all of these things that we learn are going to get learned, or are going to be made obvious to us. We're going to learn from them based on rare diseases, because these are going to be the most immediate, urgent, applications of those therapeutics. And then I think, just like with a lot of technologies, they will become mainstream. Some of the technologies that we have today, we think about the first iPhone, we think about the first high definition TV, we think about Katie Couric talking about the World Wide Web, and what is that anyway? Then it becomes sort of commonplace in your life, and our goal is to make sure that gene-based and genetic-based medicines become mainstream, and they become available to the patient populations that critically need them.